non-invasive cardiologist, currently in private practice in Gleneagles Hospital, Singapore.
Thank you. In addition to our panelists, we also have our virtual. My name is Fred Kusamoto, and I would like to welcome everybody to this clinical cases session. We're going to look at clinical cases that are challenging in either arrhythmia care or in heart failure. I'd like my co-host to introduce himself.
Hi, good morning, everybody. My name is Julian, and I'm a heart failure cardiologist from Singapore. Welcome to the session.
Thank you. Along with Julian, we also have our esteemed group of panelists. Sanjeev, will you introduce yourself?
Good morning, everybody. I'm Sanjeev Saxena. I'm an electrophysiologist at Rutgers Robert Wood Johnson Medical School in New Jersey, and I'm delighted to be with you.
Thank you so much. And Khadija?
Hi, everyone. My name is Dr. Khadija Brefa. I'm an advanced heart failure transplant cardiologist, as well as a physician scientist at the University of Arizona. It's a pleasure to join you today.
Thank you. Colin?
Hello, I'm Colin from Singapore. I'm an electrophysiologist from Changi General Hospital. It's great to join this esteemed group to discuss these complex cases today.
And Daniel?
Hi, everyone. Good morning. Welcome. My name is Daniel Yeo. I'm a non-invasive cardiologist, currently in private practice in Gleneagles Hospital, Singapore.
Thank you. In addition to our panelists, we also have our virtual moderator. Edgar, would you introduce yourself?
Yeah, hi. Good morning. I'm Edgar Tay, interventional cardiologist from Singapore. I'm also the virtual moderator for today. So please send your questions in to me, and then we'll try to get this discussed as much as we can.
Exactly right. You know, this is a case-based discussion, and we want involvement for our entire audience, and that's what Edgar's role is going to be. So he will be moderating the chat area, and we can't get to all of the questions, but he'll work very hard to ensure that the most popular questions are really addressed by our panelists and also by our speakers. So without any hesitation, I'll stop talking and introduce our first speaker. Our first speaker is Dr. Lê Pham from Vietnam. He's going to talk to us about a case of treatment of pacemaker-induced superior vena cava syndrome by venoplasty of the superior vena cava with a coronary balloon. Dr. Lê Pham.
Good morning, everybody. I am Dr. Phạm Lê Trà, known as Dr. T from Hanoi Heart Hospital, Vietnam. Today, I introduce a case report. The title is Treatment of Pacemaker-Induced Superior Vena Cava Syndrome by Venoplasty with a Coronary Balloon. The first section, background and the history of the patient. A 43-year-old male patient admitted to our emergency department for 2 episodes of pre-syncope, dizziness, fatigue. History of the patient. DDDR pacemaker implanted for 3rd-degree AV block after prosthesis aortic valve replacement 2013. No special comorbidities. His vital sign in ED, heart rate 40, blood pressure 120, 80. Temperature 37, respiratory rate 20. The second section, physical examination and investigation findings. Heart rate 40, blood pressure 120, 90. ECG 3rd-degree AV block, VRE 40 to 50. Checked pacemaker, a rough increased impedance, and no conduction of ventricular lead. X-ray, fracture of one lead. Patient was indicated for a change of the ventricular lead. Under fluoroscopy, we unable to wire thermal wire through FVC. The FVC venogram with contrast confirmed obstructed FVC, and fracture ventricular lead under fluoroscopy was confirmed. So the diagnosis is fracture of the ventricular lead, FVC occlusion, prosthesis aortic valve, DDDR PPM. So the question, which strategy did we choose to treat this patient? The perfect option, removal of the old ventricular lead and insertion of a new one through FVC to RV. Reopening FVC is mandatory. The second alternative, pericardial implant for ventricular lead. And the chosen alternative, non-removal of old ventricular lead and insertion, a new ventricular lead, reopening of FVC by a coronary balloon. So we decided to reopen FVC and implant a new lead, which was feasible in my hospital. Only extraction, not feasible. Excimer laser, not available in my hospital. Reopening achieved with a coronary balloon and insertion of a new lead into the RV. Pericardial lead, family did not desire. So we consult to the coronary interventionist to open FVC and assist with insertion of ventricular lead, using guiding catheter GR6F to engage to the FVC, using coronary wire 0.014 without curve bending to pass through obstructed FVC. Dialing gradually and carefully coronary balloon, 3.0, 20 mm, 4 times with pressure ranging from 18 to 24. Rewiring thermal wire 0.035 to FVC. Inserting the long sheet, Medtronic, introduction sheet 6F and 23 cm over thermal wire through the obstruction. Withdraw the wire, cut the hemostasis valve afterward, and ultimately inserted the new ventricular lead into the luminal of the long sheet. So it is a picture of the equipment. You can see in the left picture, coronary wire as I see on blue. And the right picture is Medtronic introducer sheet. So the clinical course, we pass coronary wire over the obstructed FVC. We can see the white arrow. We dilate coronary balloon 3.0 and 20 mm gradually in the obstruction FVC. The final result shown on the right picture, successfully implanting new RV lead on the inferior anterior septum RV. So the final section, the discussion. FVC syndrome is rare but really serious, severe and difficult to treat in clinical practices, especially with non-experienced electrophysiologists. The only way to confirm the diagnosis is with a venogram, and computed tomography cannot completely detect the obstruction in the FVC. Because of the rarity of FVC syndrome, there is no consensus or unique treatment strategy for this. Many others report successful treatment of the patient with venoplasty with or without stenting the FVC. But the complications like FVC leaking, perforation, and trauma can occur during the procedure. In conclusion, venoplasty with or without stenting the FVC is the most used and optimal option to treat FVC syndrome patients. Although there is lack of evidence or research comparing the outcome or prognosis between endovascular surgery and venoplasty with or without stenting the FVC, physicians should try venoplasty first, and if it fails, the surgery should be the last resort. By publishing this case study, we want to share our real experience and point of view in FVC syndrome treatment in our center, Hanoi Heart Hospital in Vietnam. Although we don't have all the equipment in a special way with the cooperation between EP and coronary interventionist, a coronary wire, a modified long sheet, and a coronary balloon, we treated the patient with biomarker-induced FVC syndrome and fracture ventricular lead successfully, especially in this case. Thank you for your attention. And if you have any question, don't mind to ask me. I will answer on your question.
Thank you very much, Dr. Lafan. That was indeed a very interesting case, and I think your team must be congratulated for the successful management of it. I don't see any questions in the question box. Perhaps I might start by asking, how would you manage this complete heart block after this, considering that, we think that sometimes when you have these SVC syndromes, it can be due to repeated endothelial damage. What did you all do for the heart block after that? How did you guys choose to manage it?
Sorry, I can understand your question. How can I manage
Sorry, so after you guys dealt with the superior vena cava obstruction problem and you all extracted the lead, how did you all manage the complete heart block?
I just implant a temporary pacemaker to resolve the complete heart block before we implant new leads into the RV.
So you all went through another conventional pacemaker again after that.
Yes.
Is that right?
Yes.
Okay. Perfect. Is there a concern about this problem perhaps coming back?
If he come back with another problem, we will consult to another expert to resolve the problem again. You know,
I see.
because in our center they lack of equipment and experienced operator enough to resolve this problem for